Health information exchanges and qualified health information networks are vital to building better healthcare. But these concepts are new to many people in the field. I'm Andy Reynolds with NCQA. Today on Quality Matters, we'll learn about data exchange from one of the field's leaders, Laura McCrary, President and CEO of KONZA. Laura, welcome to Quality Matters.
Thank you very much.
Let's start at the beginning. What is KONZA?
We are a health information exchange and qualified health information network under TEFCA. We provide health information data sharing services as well as analytics and alerting products to healthcare providers across the nation.
KONZA is one of now 7 qualified health information networks, or QHINs. You were number 5, so you were relatively early to that designation. Why did you want to become a QHIN?
Organizations need to share data with each other because patients get care in a variety of locations. People travel or take vacations and they might need care. It's a patient safety issue to ensure patients have their medical information in one place when they're in front of their primary care doctor or if they end up in the hospital. If all of the patient's medical records aren't there, there is a possibility that there could be a medical error. And it's really important when they return home that medical information is available to their doctors in their communities. I even saw it with my mother. Personal experience, my mother has an allergy to penicillin, and she was in a hospital that didn't have her medical records. They did administer penicillin to her, and she almost died.
You've witnessed the birth and the growth of things like HIEs, QHINs, and TEFCA. How do you think about the purpose of those things, and what's your opinion of how they're evolving?
You can't share paper records electronically. You have to digitize records to share them. The first thing that had to happen is doctors had to move from paper to an electronic medical record system. The thing that was unpredicted is that those electronic medical records in 2010 did not have a methodology to communicate with other electronic medical record systems. So funds were made available to connect those electronic medical record systems. That's what health information exchange networks do. They transmit and transform information, say, from an EPIC electronic health record system, so the Cerner system can incorporate that data into the patient's chart. These things struggled because they didn't have a common set of rules from state to state. Each had their own rules, so there was difficulty talking to the states next door. If you're in Kansas City, where Kansas and Missouri share a state line down the middle of the city, people have no idea. They're going to the other side of the road and with an entirely different HIE infrastructure. So it was written into the 21st Century Cures Act that the QHINs would be the connectivity across the nation. And the federal government would set the rules. TEFCA, the Trusted Exchange Framework and Common Agreement, that's the rules of the road. The word qualified means you have the federal government's endorsement of the infrastructure. That fosters trust because organizations that join a QHIN know those organizations have gone through rigorous testing to assure the safest and best technology. Those are key infrastructure pieces in moving data nationwide.
When you speak with people throughout the country, what do you find they misunderstand or get wrong about HIEs, QHIN, and TEFCA?
I do CME presentations all over the country. I had one doctor at this last meeting tell me he could not get medical records for his patients from a hospital down the street. And I told him exactly how he could. He has to participate in data sharing, right? I mean, it's not magic. You have to be connected to a network. Just like if you have a cell phone, you don't magically get to call someone. You have to have a network. I spend a lot of time talking to doctors and to hospitals. For them, the whole idea of the QHINs is brand new. A lot of times it's just introducing the concept that HIEs have sort of grown up, right? They've grown from being a community-wide or a statewide, and now they're national organizations that are federally regulated, often the first thing they'll say is, well, am I required to participate? And the answer is no, but it would be good to be thinking about how you're going to participate, what QHIN you're going to choose to connect to, how you're going to connect. For example, are you going to connect individually as, say, a small physician practice, or are you going to connect through your electronic medical record system? Are you going to connect through a health system you have a relationship with? There's many models you can think about. I encourage them to start asking questions. Ask their electronic medical record vendor, ask a health system that they might be in a value-based contract with, how they're going to manage this, and start thinking about the solution that's best for their organization.
Is it possible to take advantage of the benefits of a trusted exchange framework and common agreement without going through a QHIN?
The only way is through a QHIN. Let's say, for example, they're already part of an HIE. HIEs have an infrastructure to connect smaller practices, rural practices, really the last mile. The HIEs are the best at. The HIE can join a QHIN and bring their members, which is what we expect to happen in many parts of the country. We expect HIEs will join a QHIN over the next 12 to 24 months, and they'll bring their participants along. There are lots of ways to come onto the QHINs, but the QHIN infrastructure is how you connect to the rest of the nation.
What did you think it would be like when your health information exchange applied to become a QHIN, and how has the reality of being a QHIN differed from what you expected?
There is a lot more information available. It really is both a blessing and a curse. When in the past there was no information available for the doctor, now there's so much. The first problem was, how did we actually move the data from Florida, say, to New York? We've been able to solve the problem of getting the information to the doctor. It's been solved through QHINs. As we solved one problem, we've created a new one, which is there's too much information available. We've got to address this new problem. How do we consolidate information into a meaningful document? How do we make it useful for users in a way that allows them to manage all the information? We had to solve the first problem to get to the second problem. How to make information meaningful and manageable. You've got to take it one step at a time, and I feel we've had enormous success in at least addressing the first problem of how are we going to get it to the doctor.
What can you tell us about how QHINs handle claims data versus clinical data?
Everybody is in strong agreement. Claims data needs to be a part of QHIN infrastructure. The reason is sometimes claims data has information that's not available anywhere else in the QHIN. For example, there may be a physician practice in a rural part of our country that still is on paper. That physician provided care to a patient, and that information is not documented electronically, but it is in claims data because that physician submitted claims and was paid for it. The physician who's asking for information about Laura McCrary may only be able to get that information from the doctor who's still on paper. We can't leave those folks out if we want to have a complete infrastructure. So claims data is critically important as we continue building this infrastructure. Insurance companies will make the claims data associated with just the clinical information for the patient available on the QHIN infrastructure because it's important in the safety of the patient. This data has to be aggregated. Claims data has to be combined with clinical data. The two come together to provide the complete picture of data quality.
Laura's observations about combining claims and clinical data got the attention of people at NCQA.
Hello, this is Brad Ryan, Chief Growth Officer at NCQA. Laura's comments on the power of integrating claims and clinical data resonate. The real power of integration is aggregation and integration. Aggregation of all the clinical data being generated about you or your family member with all of the claims data, both your current health plan and your past health plans. So it's powerful on both levels, claims plus clinical, and aggregating the clinical and the claims data.
What Laura said about the need to join a network also got Brad's attention.
Anytime you move from one-to-one relationships to many relationships, that's the network. TEFCA is laying sort of a data fabric that it can be accessed by that network, where data about clinical and administrative parts of healthcare can be used in new ways. Until you have that data fabric, you can't apply applications and you can't make insights about what should happen next for a patient or what should have happened. That move from one to many is powerful. The booms in information technology have come from the building of networks, and that's what's powerful here.
My conversation with Laura expanded to include an underlying concept: trust.
Health information exchanges and interoperability is built upon trust. Networks have to be a trusted resource for all organizations that participate. And that's why in TEFCA, you find a common agreement across organizations. Everybody signs the same agreement. They adhere to the same benchmarks. We didn't understand years ago that everybody has to follow the same rules. I wish we would have known 20 years ago when we started building these things. Everybody needed to follow the same set of rules. If you don't have trust. And if you don't have trust, you don't have the ability to make a difference.
Brad Ryan again.
I agree with Laura on the importance of trust. And I think trust comes on many levels. The first levels are, can I legally share data with you and trust that you're going to use it appropriately? That is addressed well with the TEFCA. And then there's, can I trust what I'm going to get from you? And that's the standards around what data is expected to be transmitted and what format. And TEFCA is helping address that question. But the next level of trust that Laura also alludes to is data quality. Do I believe that data is the truth, is representing the real world? And that's the bit that we still have work to do. TEFCA does not address data quality.
Say more about that, please. How or why is data quality the missing link?
QHINs and HIEs and data vendors, they've been addressing data quality for a long time, but everyone has their own way of thinking about data quality. We don't yet have a common way of looking at data and saying, this can be trusted, this is valid. I can make treatment decisions based on this data. That's the last line in the trust equation. We're working to find a common way of agreeing on whether data can be trusted for its content, whether we can believe what's there, not just whether it was shared appropriately with the right party for the right usage. That's the part TEFCA has not yet solved, but has laid groundwork for us to collectively solve.
And as for what's at stake, Brad, I know you see this as important, not just for data exchange in and of itself. You view this as vital to the viability of value-based care. Explain what you mean, please.
Tying trust in with value-based care is the why, in my opinion, for all of this. We know that incentives have been a problem for a long time. We all want to provide better care, but until we create the incentives that reward it, it won't happen just by having data moving around. The incentives must be there. Everyone believes we should move to paying for value rather than paying for activity. It's all about agreeing on what value is. If we can't trust data used to adjudicate quality and value, then nobody's willing to be paid on it. And we've made some strides in that area. HEDIS has helped a lot. HEDIS is validated, it's audited, it's consistent, and the integrity is high. But there's limitations, mainly because of data sharing. Now with this data fabric of integrated clinical and administrative data, or claims data, aggregated across sources, if we can trust it, we can apply quality measures everyone believes and agrees on the numbers and has access to the data to take actions that control their own destiny. If they're trying to put in a value-based contract, they need to know where they stand and believe they're looking at data that's going to be used to pay them. And that's the holy grail.
Laura, a big reason for digital quality measurement is to reduce the burden of measurement. That is, making HEDIS easier to work with, for example. How do you see HIEs and QHINs relating to burden reduction?
HEDIS data is extremely important. Insurance companies are incentivized to make sure that their doctors report those metrics. It's been difficult for insurance plans to get that information. And sometimes I'm appalled that some of it's still faxed to insurance companies. The other thing that happens is, believe it or not, a nurse will get in her car and drive to a practice and stand at the copy machine making copies of medical records. We're trying desperately to move away from these antiquated, inefficient, expensive processes now that the data has been digitized. The QHIN model is going to allow data insurance companies need to be available in a digitized format. This is a huge step forward from the poor nurse driving across Kansas to get to the records.
And what's next for HIEs and QHINs? What future do you foresee?
We'll continue to build out the infrastructure. There will be more QHINs over time. There are 7 now, 5 in production, and 2 more that are in testing, and we expect to be in production soon. And it is important to make sure that model stays true, because QHINs afford the safety, security, and trust of the federal government. It's not going to be overnight. There's no magic wand. The best way to think about it is it's like laying internet cable to your house. It actually has to come to every house. The same thing is true with data transport. We're not drilling into the ground and laying pipes like that, but we are running connections across the internet through virtual private networks. So you've got to build it to the very last organization. Every organization has to be touched, and every healthcare organization across the nation is a lot. When you think of all the hospitals, the primary care practices, specialty care practices, federally qualified health centers, post-acute care facilities, behavioral health, dentistry, these all have to be part of the infrastructure to meet the needs of patients in the United States. We know we can do it. We have to have patience and perseverance, and that's what we have.
On that hopeful note, let's leave it there. Laura McCrary, President and CEO of KONZA, thank you for joining us on Quality Matters. We appreciate your time.
Thank you very much. Thank you.
Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts. We'll see you next time.